I'm going to talk you through the acute pain management. Now, this is a very, very clinically relevant topic, okay? So basically, the reason I put this, and I've got some cases at the end, which will help us to, consolidate the knowledge and put that in practice, okay?
Sadiq,
So, as we all mentioned, sorry, Manish.
so can you unshare? I'll share. I've got the presentation. I'll share now.
Okay, I've just started mine, so let me finish mine, then you can.
Oh, yeah. You carry on. Yeah, that's fine. Sorry.
No problem. So, as we already mentioned, and every talk, in the beginning of the talk, you've heard this, pain is an unpleasant sensory and emotional experience associated with the actual or potential tissue damage. So the reason that I put this definition again, that, we need to focus on two important aspects of pain, sensory and emotional. So you'll find patients who are anxious are more likely to have more pain after the surgery. So if you're trying to put a cannula in and the patient screams like anything, then you should expect there might be a challenge in recovery after the surgery is finished. Okay, so it's very important to actually focus on their psychology in addition to their physical pain. Now, post-op pain management, we know that there is a 70% incidence of patients having moderate to severe pain post-op, and we need to have a proactive approach, because unless you have a proactive approach, you won't be able to reduce their pain. The patient comfort is not going to be good, and if you have a proactive approach, you will reduce their pain. The patient will be more comfortable. They will be more satisfied with your care. They will be more satisfied with the outcome of the surgery, and it also reduces the hospital stay. Okay, so what happens if you don't do proper pain management? And this is a very important aspect as an anesthetist, okay, because your recovery nurses will love you if you do your job not just as an anesthetist but as a pain doctor as well, okay? Because if you haven't controlled anybody, your patient's pain, for doctor, it's tiring, it's time consuming, it's upsetting, it's stressful, it's irritating. For patients, it's the same, upsetting, stressful. There's a loss of faith, low mood, they become angry. And hospital, it leads to delayed discharge, it reduces patient satisfaction, increased hospital cost per patient, increasing their bed days in the hospital, and delayed discharge. Okay, so we know that poor pain management not only just leads to these problems, it also leads to the physiological issues, okay? And this slide highlights that. So if you're in pain, then your sympathetic outflow goes up, your sympathetic activity increases, gives rise to tachycardia, hypertension, and that gives rise to indirectly increasing oxygen consumption, which can give rise to myocardial ischemia. And this is very much of a problem if patient has history of ischemic heart disease, okay? So the other thing to keep in mind, as I said, severe pain can give rise to fear and anxiety, which can give rise to sleeplessness, and it also reduces the rehabilitation process. The other problem would be if somebody's in pain, then they will do shallow breathing that leads to splinting of the diaphragm, gives rise to basal atelectasis, gives rise to hypoxia, hypercarbia, and can give rise to low respiratory tract infection. Okay, and we also know, it's proved by research, that pain affects the impaired immune response. If somebody's in pain, the healing will be poor, but at the same time, it will make them prone to get infection and sepsis. Okay, and if the acute pain is not controlled well, then the patients will end up developing chronic pain. Okay, so he put up this slide. So this is what the outcomes that are expected at your F2 level, okay? And it says in the competence that you need to recognize the importance of pain control, assess the severity of the pain, the cause of pain, and manage the pain effectively and safely, and prescribe the analgesic drugs safely, okay? So now this is the most important slide, and I would say the slide that we all need to work on, because this explains everything about the applied pharmacology as well as the physiology, okay? So, the noxious stimulus that actually is sensed by the nociceptors. And then, you have these drugs that actually work at that level. So, for example, anti-inflammatories, they reduce the receptor firing, okay? So they reduce the prostaglandins, and that way the receptors aren't going to fire, or, and that way the inflammatory pain is reduced. Local anesthetic block the transduction pathway. So then it comes to the transmission. So this is where the local anesthetic work again. So we do have lidocaine plasters that we use and lidocaine gel we use in the chronic pain sector, where patients apply this in order to minimize the allodynia. Now, transmission, we do the nerve block, so peripheral nerve block or epidural is what will block the transmission of the impulses going up to the brain. And we have these drugs that actually work at the spinal cord level, including the, gabapentin, paracetamol, anti-inflammatory drugs, opiates, and alpha-2 agonists like clonidine. Okay, and then we have the opiates mostly work not only just at the spinal cord level, but also at the higher brain center level and reduces the perception. Now, talking about the inflammatory pain, we know that it leads to peripheral sensitization and central sensitization. And I think the drugs that actually work on this, it's the anti-inflammatories that will reduce your inflammation. But also, there is some evidence that opiates will reduce peripheral sensitization and central sensitization in short term. Okay, now pain management is a team game. Okay, it's not just one man show. You will have to have the rest of the team on board. So you have to have pharmacists, physiotherapists. We as anesthetists play a very important role. The nurses on the ward, the acute pain nurses in the acute pain team also play a very important role, and also the surgeons. They need to be very much involved as well. Okay, so multimodal approach is basically not just using the medication. There are some other things that you can use to minimize the pain, like rehabilitation process in the form of physical therapy. You can use some adjuvants like, hot and cold compress, cryo cups. These are the things that can be used. The cryo cups are basically used for patients with total knee replacement or any kind of knee surgery. It reduces their pain. So you're using the physical modalities of treatment. You can do regional blockade. You can try things like acupuncture. Currently, we don't have acupuncture available in our trust for acute pain. We do it for majority of times for chronic pain patients. And you have rehabilitation program. So educating the patient is also very important. And there are places like, in Scotland, they have bone school where they will actually educate the patient about knee replacement or hip replacement or shoulder replacement and make them prime to understanding that these surgeries are big, they are painful. And then, when you actually are in the process of rehabilitation, you have to cope with the pain. So there are some other complementary therapies like cognitive behavioral therapy, TENS machine, or sort of, a guided imaginary that can be tried to reduce the pain. Okay, so he talked you through about the paracetamol, anti-inflammatory drugs, opioids, and non-opioid drugs like antidepressants, antineuropathic agents. Ketamine is another drug that, we try in the acute pain setting as well as in the chronic pain setting, and the local anesthetic blockades in the form of epidural block and the peripheral nerve block. Okay. Now, it's very important to keep in mind that whenever you work as an anesthetist and you get called in the middle of the night and the patient is nearby mouth, you need to know, okay, what are the other ways that I could deliver the pain relief? Okay, so oral route is the most commonest route that we all actually, sort of prefer. Mucosal or buccal, then this is another route that people forget. It's a sublingual buprenorphine. It works very well for acute pain scenario. Also, things like, nasal fentanyl is used, nasal midazolam is used for pediatric population as an anxiolysis as well as pain relief. Cancer patients, there is a rectal route, so intramuscular, subcutaneous route, as they would use sort of morphine. Then we have topical and transdermal route. So you heard about the capsaicin cream. That's a topical way of delivering. Same with lidocaine gel is a topical way of reducing. Instagel. Obviously, Instagel has got lidocaine and chlorhexidine. So it's a topical way of reducing the pain. And transdermal route. So patches, pain patches in the form of buprenorphine patch or fentanyl patch can reduce the intensity of pain. And then inhalation route in the form of Antonox, the nitrous oxide. And then you have intrathecal drug delivery system, you have epidural drug delivery system, and infiltration around the nerves using the nerve block or peripheral nerve catheters. Okay, so this is like a typical referral that you will come across as a SHO. 65-year-old, operated for laparoscopic cholecystectomy under general anesthetic this morning. She's got hypertension. She suffers with low back pain. She's on Zomorph, gabapentin, ibuprofen, and paracetamol. And you get called at 9 o'clock saying, well, she's in pain. come and assess her. She's in a lot of pain. So, you know that she's already on Zomorph, she's already on paracetamol, ibuprofen, and gabapentin. You think like, what the hell I'm going to do? How I'm going to assess and manage her pain? So this is where I think knowing the pharmacology and the practical application of pharmacology makes an important plays an important role. Now, what are the goals for the pain management? You want to educate your patients. You want to tell them about anticipation of the pain. You want to deliver the optimal pain relief, minimize the side effects and the complications, and it needs to be efficient and cost effective. Okay, and these are all ideal things that you would like to do in order to achieve a good pain management. Okay, now there is an evidence that chronic post-surgical pain is reduced by early analgesic intervention. So if you, as an anesthetist, manage their pain well in the post-op period, they will less likely turn up to the pain clinic because the chronicity of pain is reduced if the acute pain management is done well. Okay, moving on to the next slide. So we all heard of this. He mentioned about the WSA, World Federation, for the analgesic ladder, WHO pain ladder, where you start with the oral simple analgesics like paracetamol and anti-inflammatories, and then you go on to the weak opioid like codeine or tramadol, and then you go on to the strong opiates. So we have heard of that, and we've heard this phenomenon as well. You start with sort of weak opioids. Paracetamol you start with, then anti-inflammatory, then weak opiates. So that's the oral analgesia bit. And then when you're actually giving a parenteral analgesia in the form of a PCA, you would go with the bolus, which helps with the breakthrough pain. And then you can also put up a PCA, background infusion, that will help your background pain. Okay, so opioids, you heard from E about the mechanism of action, and this is the important slide. If you remember this slide, your Viva part of the opiates will be covered. Okay, if they ask you how does opiates work, say it's a G protein related action. It closes the voltage gated calcium channels. So once you get the calcium channel closure, it reduces the release of the neurotransmitter. Okay, so that's how it works. The other thing it does, it causes hyperpolarization, and if you cause hyperpolarization, that also reduces the neuronal excitation and conduction. So high level of potassium and lower level of calcium. So overall, there is a reduction in the transmission of the nociceptive impulses. Okay, so opiate analgesia, so how does it work? It not only works just at the spinal level or the peripheral level, it also helps to work at the descending inhibitory pathway. So we heard about the pain pathways where Mahesh explained that there is also a descending inhibitory pathway where serotonin and noradrenaline play an important role, and it works at that level too. Okay, so this slide was put up by E as well. There are three, we have naturally occurring compounds of opiates, like morphine, codeine, thiabine, and papaverine. And then you have semi-synthetic compounds and you have synthetic compounds. So the stuff we use in our day-to-day practice, fentanyl, L-fentanyl, remifentanil, all these are sympathetic compounds, apart from morphine, which is naturally occurring compound. And the dimorphine, dihydromorphone, buprenorphine, these are semi-synthetic. Okay, and that is usually your MCQ question that's hidden there. All right, so weak opioids, we class these as codeine, dihydrocodeine, and tramadol. Now, the reason I put up tramadol, because I think there is always a concern, you get told, okay, don't write up tramadol if they're on morphine. And when you're filling up things on e-meds, it splashes up. But if you look at the opiate activity of tramadol, it's about less than 40%. Okay, so if you look at the serotonin effect, about 20%, noradrenergic effect is about 40%. Okay, so it's mostly the serotoninergic and noradrenergic effect rather than the opiate effect. That's how the tramadol works. Okay, so if I see like that lady, middle of the night, you get cold, I know she's on morphine, but the other drug that you can try is tramadol, because it not only just works at the opiate receptors, it will work at the serotonin and noradrenaline pathway too. Okay, now it is a synthetic phenylpiperidine analog. It's a weak opioid, and basically you can give as a dose of 50 to 100 milligrams every 4 hours. Maximum is 400 milligrams per day. Things to be careful with if somebody's epileptic, don't use tramadol because it reduces the seizure threshold. It can give rise to convulsions itself, but it's very rare. And it has psychiatric reactions, so it can cause hallucinations and confusion. And my rule is, if anybody is more than 70 years of age, if they're elderly, if they're frail, then I don't usually like using tramadol, because elderly people respond to tramadol very badly. Okay. The other bit to keep in mind, as constipation is less of an issue with tramadol as compared to sort of morphine. Now, there are interactions, and he mentioned about these interactions. So when you're using the tramadol, remember there's an increased risk of seizures. It can cause sort of, reduce the seizure threshold if it's used with tricyclic antidepressant. Carbamazepine reduces serum tramadol levels, and warfarin effect is increased with tramadol. So you need to monitor the INR beforehand and adjust the warfarin dose. Okay, so that's tramadol covered. Strong opioids, oral morphine. You heard about the MOP, COP, NOP, and DOP receptors. So those are the receptors you'll have to learn for the exams. And the morphine, we know it's metabolized in the liver in morphine 3 glucuronide, morphine 6 glucuronide. Current dosing for the kids between 2 and 12 years of age is, oral morphine 200 to 300 micrograms per kilogram, okay, every 4 hours. And for breakthrough and rescue doses, you can give 1/6 to 1/10 of the 24-hour dose. So, and I'll explain that a bit later. So if you're giving somebody a morphine, and if you're titrating the dose, and if they're still not responding, you need to consider the adjuvants. And the adjuvants are like medications like tramadol, gabapentin, pregabalin. You need to stop upward titration of the dose if the pain is not relieved or unacceptable adverse effects are occurring. So if somebody's actually getting respiratory depression, or they are, violently sick, then those kind of side effects you should think of not using or increasing the dose of morphine. Okay, now fentanyl, you heard from me. So fentanyl is 100 times potent. Be very careful, because I see a lot of times you will come across patient on 12 mics fentanyl, but it's actually nearly 50 milligrams of morphine. So don't think, oh, just 12 mics, let's pump it up to 25 mics. If you're putting 25 mics, it's a big jump. So, it will be like, 100 milligrams of morphine a day. So think about that very carefully. Okay. The other important bit to keep in mind, the practical advice, is if you take a patch off, that doesn't mean the body's levels or serum levels of fentanyl will disappear. It takes good 24 hours, for the fentanyl levels to reach, and it takes about 72 hours for the fentanyl levels to drop. So, if you take the patch off, that doesn't mean the effect of the medication is gone. And if you put a patch on, that doesn't mean it kicks in straight away. You need to give good time before you start to assess its efficacy. Now, fentanyl is also available in the form of, you can use it sublingually in the form of tablet, buccally, and there are lollipops of fentanyl, and also it can be used nasally. And this is basically used in the cancer sector. Okay, so buprenorphine is another very, very, very good drug. I class it as a very good drug because it's a partial agonist. The problems of respiratory depression aren't there. We use quite commonly in chronic pain practice. We use it in the form of a patch. You can start at a 5 milligram patch. As I said, as E mentioned, the 5 mics patch per hour is equivalent to about 12 milligrams of morphine. So, it's a good drug. And it has a significant first pass metabolism, so that's why the sublingual route is preferred. So if somebody's showing withdrawal symptoms, or if somebody's on high dose morphine and they are complaining of withdrawal, and you're trying to reduce the dose of morphine, but you want to avoid the withdrawal symptoms, then you can actually try buprenorphine as one of the options. Okay, so what are the adverse effects? I think I'm not going to go through this slide. He's already covered. These are the side effects of morphine-based medications: dry mouth, bradycardia, respiratory depression, urinary retention, and rash, pruritus, sweating, and urticaria. Okay. Other side effects are on CNS: confusion, euphoria, dysphoria, and the long-term side effects. And these are more of an importance for us to tell the patients that don't take morphine for a long period of time, because you will become dependent on that. You might get the withdrawal symptoms. You may develop adrenal insufficiency, giving rise to infertility, depression, erectile dysfunction. and also has its effects on immune system. So patients who are on high dose morphine, you will realize they get frequent chest infections or urinary infections because the immune system is actually in the boots. Okay. Now, in general, prescribing rules. So when you actually, the traditional approach, the PRN dose, it should be 1/6 of the total dose in preceding 24 hours. So if somebody's taking 40 milligrams of morphine, okay, you divide it by 6. So, you would say about 7 milligrams. So that would be your PRN dose, okay? So now this is very important bit that I would like you guys to take home is if you all have smartphones. So download this app called as Opioid Calculator. It's an app from Royal College of Australia and New Zealand, Faculty of Pain Medicine. The beauty of this app, in the middle of the night, you want to do an opiate conversion, you just dial in the dose of the drug where you want to calculate, and it gives you the traffic light system. So it will go on orange or it will go on red. So, morphine, obviously I've just kept this simple 80 milligrams, but you can add in all the different types of opiates and it will give rise to a calculated. But once you go beyond 120 milligrams of morphine equivalent per day, it goes red. And it tells you the patient is on a high dose opiate. So anything more than 120 milligrams in 24 hours is a high dose morphine. Now, if somebody is on high dose morphine, what are the adjuvants? So we use antineuropathic drugs like gabapentin, pregabalin. You can use IV lidocaine infusion. You can use things like ketamine. Okay. So let's just talk a bit more about PCA, the practical approach. So PCA, the reason we give that because patients have a choice to administer the drug if they are in pain, and it allows basal infusion and a demand bolus. So the overdosage is avoided by limiting the amount of number of bolus doses set in the period of time. So that's the whole beauty of PCA. So less likely patient, if they're very sleepy, they won't use PCA, so less likely they will get the overdose of the drug. Okay, so dosing. Now dosing is, this is what we use for morphine, 0.5 to 2 milligram, up to 2 milligrams, 5-minute or 10-minute lockout, and you also can use a background infusion. Fentanyl, similar way, 0.5 to 1 mic per kg. Remifentanil, PCA. These are going out of fashion because of the concerns of respiratory depression. And, you need to keep in mind every time you write up a PCA, please write up naloxone because, if there is a pump problem, if there's a pump failure, or if the patient has actually over-delivered the drug, or if they are morphine sensitive, you need to have naloxone available for people to treat the opioid toxicity. Okay, so case scenarios. Let's quickly go through this because this might be useful for you guys. So, 65-year-old female, post-op cholecystectomy pain, day 0, complaining of severe pain. Now, basically, she's not someone who's on opioid, and you could actually give her some IV morphine, and you can titrate up the dose, and you can try and manage her pain. You can look at if she has any contraindication for any anti-inflammatories of Tramadol. She's 65, so I might use some Tramadol. Now, another case, 72-year-old female, post-total knee replacement, severe pain. You could try things like pregabalin or gabapentin, and we know that these medications do reduce the opiates in the post-op period, and that's a part of the enhanced recovery program now. People do get prescribed pregabalin or gabapentin beforehand, so they don't have to take morphine in a higher quantity. Okay, so another case scenario, an opiate tolerant patient, and this is something that I want you guys to focus on. If somebody's taking 200 milligrams of sustained morphine twice a day, and they're needing an emergency laparotomy, and they are nil by mouth post-operatively, how would you manage their opioids? Okay, they're nil by mouth. So problem is if you stop their opiates or if you don't deliver their opiates through any other route, they will develop withdrawal and they will also scream in a lot of pain after the surgery. Okay, so the way to calculate is you convert their oral dose into IV. The conversion is 3:1. So, if they're taking 400 milligrams of morphine a day, you convert that over, divided by 3. So that's 133 milligrams of morphine IV. And you have the background infusion. You set the background infusion 5.5 milligrams per hour. Okay, and the bolus dose is 50% of the hourly background infusion. So you can give them a bolus of 2.5 to 3 milligrams. That way, you will give them a pain relief, and you will also avoid the withdrawal symptoms. Okay, so that's my presentation. I've whizzed through that because of time concerns. So anyone has any questions for me before? Manish, you can take over now. You can upload your slides. Manish, are you there? Manish?
Yeah, I'm here. I'm here.
Okay, so can you upload your slides, please?
Yeah.
Does anyone have any questions for me, guys? I think, so the important bit to keep in mind, if somebody is on high dose opiates, you definitely need to, okay, somebody's asking about magnesium for analgesia. So it works as an NMDA receptors, okay? So that's the mechanism of action. And I think magnesium is basically like a wonder drug, right? You use it for all kinds of things. We use it for neuropathic pain. We also use it for patients with fibromyalgia. At times we use that as an infusion, and that can help the pain.